Now, when it comes to fixed beliefs or premises or paradigms or theories, one of my teachers said, never marry a theory in a state that doesn't recognize divorce. Remember that all these ideas that we use in science are operational tools, and science advances by changing their premises, paradigms, theories, etc., over the course of time. That's the nature of science. And they're no more than operational tools, and they should be regarded as such, not as something fixed in stone. Now, this afternoon, Janet Fetkewicz and I will present demographic and descriptive aspects of retractors. We're going to tell you about a group of people, mostly women, there's some men, in this group who have been through the whole process of developing false memories, pseudo-memories, and the nature of what they experienced and what it felt like and what they experienced as they came out of this morass. Janet's going to lead off with some of the basic data on this group. Janet.
Thank you. Need your glasses? In starting to look at this data, I just want to say that it was rather difficult to try to compress it all into a short period of time, and we're just choosing a few pieces of information. Actually, there's so much, and hopefully we'll be able to present it in more detail at a later date. Also, for me, having spent the last 2 years talking to a number of individuals who've been through an experience with false memories firsthand, and trying to gain some understanding of that process and relating to those people, it's been difficult personally to put this information into percentages and raw data and try to choose some descriptive characteristics, knowing that each story is different in its own way, and yet they're also tied together. So having said that, I'll just describe basically this survey data, the survey that we sent out to 100 individuals. Those are people who contacted the foundation, either just requesting information or wanting to share their story, that sort of thing. We sent surveys out to the first 100 of those people, and this analysis is based on 40, which have been returned to this point. So I'll be reporting on that number. Obviously, data is subject to limitations, and we're aware of that. It's totally descriptive. It's composed of the perceptions of these people who completed the surveys, and it's retrospective, as I said. It's a small group, small number at this point, and we have those concerns, but we think that it bears analysis. The primary purpose of the survey was basically to identify some of the demographic data, to describe the process and the patterns involved in recovery of memories, the accusations themselves, and the process of recanting. And we think we all know it is a process. And also, additionally, to have another description on paper, if you will, of the stories we've all been hearing. We've already had a number of very eloquent descriptions that are contained in the books outside of this room on the table, and I think this is just one more piece of information. So also I want to say that before I continue in describing some of the data, it's important to note a couple of aspects that we've noticed in regard to the survey. Much of this data is really consistent with the family survey data that was reported on in 1993. And this is interesting, I think, because the group of individuals who completed this survey, the retractors who sent back their surveys, are not sons and daughters of family members who completed the family survey. I think there's a perception or a misperception that all of the retractors are sons and daughters of family members who joined the foundation and perhaps the retractors have caved into the pressure and given up their memories because of that. But at least this group of people is not representative of that fact. The family survey data, by the way, is based on 284 surveys. So I'm just going to refer from time to time to that data to just point out some of the consistencies and if I have a chance, also some of the inconsistencies between these two groups of data. So I know, according to my watch, it's nap time, but I'm going to just run through some basic stats on demographics, and I hope you don't go to sleep. If you do, wake up in time for Dr. Lief. The retractors who completed the survey were 92.5%, 37 of them were female, and about 7.5 male. I know I was speaking to a male retractor last night who's very upset about this. He feels that there are many more men out there, and John, if you're in the audience, I can only report what I have in front of me. You can maybe find the other guys and have them send in a survey. Actually, that's very consistent as well with the family survey. It was 92.2% female. Well,
despite all our work,
we thought we checked this. These people were, this is the past life, year of birth. Well, I'll talk about the year of birth while they're fixing the slide. It
illustrates the upside down nature of the whole experience.
It's not all that fascinating, but the average year of birth is 1956, and the average age of this group of retractors is 38. They range in age, in birth years, from 39 to 1975, which again is very consistent with the family survey data. Age ranges were from, birth ranges were from 1933 to 82. It'll be interesting to see that slide if it ever comes back, but I'll move on. I can't say much more about year of birth. Fairly highly educated group of people, 50% college graduates and about 17.5 graduate school. Family survey again, slightly higher, reported slightly higher educational level, but fairly consistent. About half, almost half of these individuals are married, about 30% are divorced, and about 22 single. And again, that's also consistent. Very large number of these retractors have children, almost all, in fact 33, and report a moderate or highly successful lives. So I guess what I'm saying is, in the whole, it doesn't sound like we're looking at people who managed to do quite a few things given this experience. I just want to talk a little bit about some factors involved in childhood history. Number of children in the family of these individuals was average of 3, and family sizes, oh, my slide, there you go. You can watch that while I'm saying this other stuff. Does look nice, doesn't it? Family sizes were from about 1 to 7, and we had about 5 only children. We didn't find any significance in the birth order of these individuals. They told us a little bit about their childhood. 85% of their parents remained married, stayed married. Dad, for the most part, I think except for one person, worked full-time out of the home, and mom stayed home, 55%, with the kids. Some moms worked part-time, but most stayed home. They were fairly active in religious groups, and parents were fairly active in their school and social lives, in the kids' school and social lives. And that was indicated by things like helping with homework, attending parent-teacher conferences. And we asked these individuals also to rate the time they seemed to spend with their families compared to peers. About almost 60% said they seemed to spend at least average or more than most of their peers in terms of the time spent with their families. We also asked them to report, again, this is retrospective, and this is their perception on their general adjustment as a child. The average response was above average. High school and elementary school achievement, again, was generally high, at least above average. And a reported general sense of well-being as a child was also average to above average, as well as peer relationships. Those things were all fairly positive. Let's see if this next slide works. Oh, good. Okay. We asked these subjects what their perception of the family relationships were during growing up, during therapy, and currently or after therapy, meaning after their memories of abuse were recovered. You can see, I think, that this is the general family response, that actually they were able to respond to this sort of statement. As I was growing up, I felt my family was more or less a normal family. They could either strongly agree or disagree, strongly disagree, that sort of thing. And you can see that most of them, before therapy, many of them tended to agree with that statement. During therapy, obviously the disagree proportion is much higher. And after therapy, I think it's interesting that they sort of stayed slightly higher. I can quote percentages, but I don't think that's too relevant at this point. This is their perception of the level of satisfaction in terms of the relationship with mom. Again, it's not surprising that during therapy there would be disagreement with that statement. And the last slide is the perception of the relationship with the father. I think that's pretty self-explanatory. In most of these cases, the father was accused. So we also, just to sort of delve into some additional family background, I won't have time to go into everything, as I said earlier, asked about general questions like problems with alcohol and drugs in the family, substance abuse. Among this group, 67.5%, which is pretty high, said that one of their parents had a substance abuse problem. In the family survey, that number was 22%. However, when the question was asked regarding the retractor, that figure was fairly consistent with the family survey data. The subject in this survey reported that about 32.5% had a problem with alcohol or drugs. And again, we're not looking at, we're trying to identify some stressors in childhood or before this memory retrieval experience. We also looked at the history of psychiatric and psychological treatment during childhood and adolescence. Only 5% of these people had any kind of treatment during childhood, and only about 11 or 27 or so % had psychiatric or psychological treatment during adolescence. We assume that, and we know this from the survey, that people did have various stressors prior to entering therapy, and I think Dr. Lief will go into that a little bit in more detail when he talks about their presenting problems. But in general, there were issues with loss and anxiety-related issues, marital problems, that sort of thing. We thought maybe, and I guess this has been said by other people, that perhaps a disturbance in the relationship among family members directly prior to the patients entering therapy would somehow motivate them to recover these memories of abuse. So we asked the retractors in this survey to talk about or to comment on the quality of their relationships 1 to 2 years prior to these allegations. So you can see that they were able to choose whether the perceptions of the relationships were very positive, somewhat positive, average, somewhat poor, very poor. And 1 to 2 years prior to the allegations, in general, they were fairly positive to average. I'm going to talk just a little bit about the accusation and some of the issues around repression before I turn this over to Dr. Lief. 80% of these individuals accused their fathers after they recovered memories. And you can see that quite a large number of mothers were also accused. Obviously, these represent a number of cases in which there were multiple accusations, especially this tannic ritual abuse memories, in which for the most part every category there was an accusation. The age that these individuals were at the time they were recovering memories, the average is around 30, and again that's pretty consistent with the family survey data. And almost all, 37, reported that their memories did arise in the course of therapy. The 3 that did not sort of interested me because I wondered why, and they happened to be 2 people who were involved in a support group type of treatment, and 1 person who was involved in a relationship with an individual who behaved very much as a therapist and encouraged her to read the self-help literature and asked her to imagine abuse by a relative. So, in this sense, it really was just like a therapeutic relationship. We also asked whether a therapist had ever suggested that the retractor was abused before he or she recovered their first memory or mentioned the possibility of abuse, and 33 out of 40 said yes, 82.5%. And if you heard Dr. Lindsay speak this morning, I think that was first on his list in terms of areas for justification for concern about recovered memories. We looked at some of the starting and ending ages of the recovered memories of abuse. What's kind of remarkable in this group of subjects is that about 37.5 of them recovered memories of abuse that began before the age of 1. It's a little skewed because it includes 2 people who recovered memories of abuse before birth. I think they probably saw that therapist Dr. Opshe was talking about. So intrauterine abuse. About 40 additional percent recovered memories of abuse before the age of 6. And I think what's interesting at the other end in terms of the ending ages of abuse is that a few, I believe 3 people said that their memories, their recovered memories were of continuous abuse. In other words, the abuse was ongoing. They entered therapy maybe in the afternoon after having been abused that morning, I don't know, and recovered the memories of continuous and chronic abuse. Also, I think about 35% remembered abuse ending at age 15 or after, later. And again, it's somewhat consistent with the family survey data, except for that group that remembered before 1. About 40% remembered abuse before age 3, and another 26 or so % remembered abuse before age 6. The frequency of abuse in terms of how many episodes we also asked about, and the average response was many, that it was chronic abuse. They could have responded, one episode or several episodes as well, but the average was many. And again, the average in the family survey was also many, although in the family survey there was a lot of response in terms of that information having been vague to the parents who were accused, because they were never told exactly how many accusations they were the child was talking about. This is a slide in terms of how many years. Oh, this is terribly out of focus. Okay. The number of years the memory was thought to have been repressed. Average is about 25. And you can see, I think, that most of the repressed memories fall between 10 and 40 years length of repression. How am I doing for time? Okay. I'm going to not end my talk, but I'm going to allow Dr. Lief to sort of continue it, because what we're talking about is tied together. Dr. Lief is going to discuss some of the more clinical issues and some of the information related to therapy itself. And if hopefully he has time, maybe can get to the meatier information contained in some of the open-ended questions, which is quite fascinating. Thanks.
Thanks, Janet. I think you can see that what we have here is a wealth of data. It's impossible to really transmit all this information in the short time available. And it will take a series of presentations to really communicate all the data that we've obtained. And but what I'll do is try to give you some of the highlights in the next few minutes. First thing we have is the presenting problem. And this in descending order of frequency, you can see that this has family and marital problems, depression, eating disorder, anxiety and stress, suicidal, emotional impact of, I guess this means a medical illness, sexual abuse, only one presented with this as a presenting problem, sexual orientation. I think there was one case of gender dysphoria in this. That's what's meant by sexual orientation. It was not a question of someone being gay, I don't believe. Substance abuse, one. Sexual dysfunction, one, so forth. Incidentally, well, this was mentioned as in an earlier talk about the frequency of sexual dysfunction being linked with sexual abuse in childhood. I did a study of 150 women with inhibited sexual desire. You would think that there would be a very high percentage of a history of childhood sex abuse in that group, and we found it to be 9%. So there is not an automatic connection between sexual abuse in childhood and sexual dysfunction. Death of a relative, one. Rape, sexual harassment, so on. So those are some of the presenting problems. And here are the diagnoses given as, now remember that these are the subjects or patients as they reported this. MPD, the largest, 42%, PTSD, 35%, and you can read that, depression. And a lot of them didn't know what the diagnosis was. And borderline personality disorder was also high. And I don't know what kind of diagnosis this is as incest survivor over here, but see, I can't get this to work. But that's hardly in the DSM-4. And same thing with codependent or SRA survivor. That's hardly a diagnosis. I think that's all the slides we have. Now, I want to use the rest of our time to deal with some of these open-ended questions. And the first one was, how would you describe your experiences as the memories evolved? We may not be able to get through more than one or two of these open-ended questions. A number of themes emerge from reading the retractors' subjective feelings as they describe the process of developing pseudo-memories. These themes are: 1, a need for an explanation for their mental and emotional disturbances, a search for meaning. 2, a need to work hard at therapy. That therapy is the salvation. That without therapy they will go crazy. With therapy there is some hope. Eventually, of course, the hope leads to disillusionment and demoralization as they become sicker and sicker. There is an enormous positive dependent transference on the therapist. His or her attention and support means everything to the patient. Usually the therapist rewards the emergence or recovery of memories. 4, in most instances, therapy is a form of miscarried therapy. Stated more bluntly, a form of malpractice. The subjects of patients were ill before and then made much worse. They feel even more worthless, hopeless, and suicidal with or without MPD or SRA. In the process, there are some who make their identity out of becoming a survivor and or a victim. Now, the observing self does not disappear totally. You all understand that each of us has an observing self and a participating self. We can watch ourselves in action and so on. This observing self, to some extent, remains intact. This is an item that varies from subject to subject. Now, I'll try to illustrate these themes by quotes from some of the cases. The need for meaning. One said, overall obsession, doubts, many doubts. It was like having a strong religious belief at times. I needed to believe in the abuse to explain all my emotional problems. It helped me make sense of my life. It explained everything. Now, in this example, you see the conflict between the observing self, still partially at work, and the need for an overall explanation. The latter is usually stronger than the doubts, at least in the beginning. And here's the way another respondent put it. After the first 2 weeks in the hospital, I was concerned that I had no memories yet. So I pressured myself to start remembering. I had a feeling that my therapist would scold me or be disappointed in me if I didn't remember something. I was scared not to remember. I had many, many doubts, but my therapist didn't respond well to my doubts. She seemed more interested, more responsive, and more sympathetic if I suspected abuse. When I finally, quote, gave in, end quote, and started remembering abuse, I felt many emotions. Very scared that I may be totally wrong, but relieved that I finally had something tangible to blame my problems on. Inner peace, somewhat. My therapist and staff at the hospital showered me with attention and care, especially after the memories emerged. The more traumatic the memories, the more attention I got. I felt loved. The attention was very gratifying. However, through it all, I always had a bad feeling that these memories were all fabrications. I tried not to think about that, though, because I relished all the attention I got by being an incest survivor. This quotation illustrates many of the themes. There is a conflict between her observing self, which produces doubts, and the need for the explanation and the search for meaning generally wins out. It also illustrates the enormous dependent transference on the therapist and the staff, and it illustrates the nature of the reward system by which the therapist facilitates the process of recovering memories. She was rewarded with attention and care, and she mentions that the more traumatic the memories, the more attention she got. This is certainly anti-therapeutic and illustrates the damage created when the therapist is cast and casts himself or herself in the role of parent, or even more, a magical caretaker with the power of making the patient better or sicker. One patient said, "When I told him I did not think some of these things happened, he would tell me the only way I would get better was to trust him and my memories, or I would go crazy." I became suicidal and had a number of hospitalizations. I was afraid that I would never get out of my depression if I didn't do this memory work. I never wanted to believe that I had been abused by my mother, and I doubted it all the time. My therapist insisted that my mother was a sexual addict. My doubts, I believe, kept me feeling so much shame. During this therapy, I was hospitalized 8 times because I was so suicidal. When I doubted the memories, I was told I was an MPD and that the real me was in denial. At the same time, I became increasingly very dependent on my therapist for all of my support. I had destroyed my other relationships, and he told me that he was the only real support I had. Once he convinced me that I was an MPD, I was sure I was crazy. And quite honestly, I got a lot of attention in the hospitals for this. I also enjoyed all the attention given to me by my therapist. And the need to work hard at therapy is illustrated many times, and I'm going to skip that, but I want to zero in on the positive dependent transference on the therapist, because this to me is a key, maybe the key element in this whole process. One subject, patient, whatever you want to call it, said, "I caved in. Maybe I was abused. It was strange. The therapist was actually happy." We have an answer. At this point, I still had no memories, only a slight doubt. Then came the courage to heal. Boom, bang. I began spouting horrendous stories of childhood molestation by my father. Each session, my therapist was more pleased. Each session, I added more and more. Another one said, "I put all my faith in my therapist. I wanted an easy solution to my depression. Memories emerged like clockwork. From nightmares, detailed and bizarre, everything that came out was cleverly integrated and packaged by the therapist. And quickly I learned to do that myself. It was easy to draw any detail or experience into support abuse or to be another aspect of it. The mind is incredibly malleable. What was missing for me was strong and consistent emotion. The memories lacked dimension. My therapist said I was the most repressed client she ever had. Now that's an interesting comment, because in most of these cases there's a lot of emotion. And it seemed this fact that she did not have strong emotion seemed to help her in recognizing that these were pseudo-memories and not real ones. But confabulations and pseudo-memories are generally accompanied by very strong, intense feelings, which generally make the patient sicker and sicker. Again, stress the nature of the relationship of therapy and therapists. I was falling apart emotionally, and I looked for a counselor to go with the word codependency in a Yellow Pages ad. My counselor told me that guided imagery or creative visualization was very powerful, effective therapy. She told me my mother's numerous miscarriages meant that I had probably been sexually abused and repressed it. We started guided imagery, which she said was like dreaming when awake and full of symbols and memories which could be interpreted. I started being anxious around my daughter, afraid that I would have an impulse to sexually abuse her. My therapist pounced on this piece of information as proof of my own suppressed abuse. To recover and keep from abusing my own daughter, she said I had to recover memories of and heal from my own abuse. I started doing guided imagery at home and recovering memories. But the anxiety around my daughter increased, so I got deeper and deeper and deeper into the therapy, trying to get back to normal. Finally, I went into a treatment center and was diagnosed with obsessive-compulsive disorder, placed on medication, and exposed to Alcoholics Anonymous. Both have helped me slowly return to sanity. Now that's interesting because it brings up another question, and is how do you come back to normality? How do you recognize that these are pseudo-memories? And this reference to obsessive-compulsive disorder indicates that there are some patients who have pseudo-memories based on obsessive ruminations. And Lipinski and Pope, our own Harrison Pope, have written a piece about this, and it's abstracted in the current issue of the Harvard Mental Health Letter. And that cites 3 cases of obsessive-compulsive disorder in which there are rather horrible memories, ruminations, which are viewed by the patient and by the therapist as flashbacks and evidence of sexual abuse in childhood. So this, we can thank them for drawing this to our attention. I could add 1 or 2 of my own cases to their caseload where this certainly has been true. So again, what can you say? Appropriate diagnosis and appropriate therapy. These patients respond to anti-obsessive medication like fluoxetine or clomipramine, and they do very well with this medication. So again, once again, we're in the process of trying to educate psychiatrists and psychologists and mental health professionals that there is no substitute for appropriate diagnosis and then appropriate treatment. Well, let me go on to another question, and that was describe any contributing factors, events, or media which may have influenced your thoughts, feelings, and doubts. The most important influence in the development of pseudo-memories is a therapist. I hope I've illustrated that. I have many more illustrations which time doesn't permit me to relate. In addition to the therapist, other influence mentions are groups, books and articles, talk shows, movies. Here's one comment. Like all these influences, the therapist was the most powerful. Speaking of a woman therapist, one of our respondents said, she, an incest survivor herself, said to me during one of my earliest appointments, like an alcoholic can smell another alcoholic, an incest survivor can smell another incest survivor. Now, I leave it to you whether that's good therapy. Anytime I denied an abusive memory, my psychiatrist would become sullen and even hostile. Bringing new or worse memories of abuse to the psychiatrist would be rewarded with praise of my courage and hugs all around. that's the kind of therapy that goes on. Now, while bad therapy can have an enormous influence in the development of pseudo-memories, good therapy can have a healing influence. Several examples. I had a new therapist whose interest in speaking with me and not my alters. The biggest thing that gave me doubts was that I got away from that therapist when I re-entered school and functioned with real people again. Another example. I was referred to a psychiatrist, and maybe this is the same one I related earlier, who finally diagnosed and treated my obsessive-compulsive disorder. Now, sometimes the memory of sex abuse in childhood is a screen memory for a lot of other traumatic situations. And since this leads right into Dr. Ganaway's talk, because that's one of the main subjects of his presentation, let me cite that and end without being able to get to a vast amount of material that, if time permitted, I would be able to share with you. But one respondent pointed out that moving from a bad therapist to a good therapist made her realize that her memories of sexual abuse only hid memories of genuine childhood trauma. She spent 1.5 years in psychotherapy after she finally realized that her memories were false. During that time, she recognized what had really happened to her. I did have childhood trauma. I was hospitalized with polio when I was 3 years old. I've learned that I was taken away by a nun from my parents and did not see them for 15 days. I was tied down during the acute phase because it was believed then that it was during that time that damage or paralysis occurred. And they wanted to keep me from moving. You remember during the polio epidemic, that was a common thought, that you'd had to keep people from moving, that the movement would bring on paralysis. There was no validity to that at all. My left leg was affected by the polio, and so was my larynx. And then some other people in the family died. I can't go into it all. She said I'd wake up in the middle of the night screaming. And my mom would pick me up, and she said I just keep feeling, she said I just keep feeling her face as if to be sure she were there. I couldn't be left at the day camp or the church nursery because I'd cry and get stomach aches. I also remember being very young and going into my parents' room to see if they were breathing. I suffered from asthma. Now, these traumatic experiences were not dealt with at all during the time that she was bringing up all these pseudo-memories of sexual abuse. Well, time makes it necessary for me to stop here so we have time to give Dr. Ganaway his turn. And I'm at some other conference or in some other way, we will let the group know the rest of the data that we have accumulated, which is considerable. Let me have